Okay, so good evening, everyone. I'm Sharif Awad, consultant bariatric surgeon at EMBMI Derby Hospital in the UK. And this evening, it's the 27th of July, 22. Welcome to another BOMSS educational webinar. We have an absolute expert to deliver our webinar tonight. But just before we get started, once again, thank you to Gore for sponsoring the session tonight. And just an advert for the next two educational activities that BOMSS are running. So we have the Journal Club on the 10th of August. So the team from Phoenix, led by Peter Coe, will be presenting their Journal Club papers. And the next educational webinar on the 4th Wednesday in August, the 24th of August, will be Professor Iskender Idris from EMBMI in Royal Derby Hospital. And he'll be talking to us about mechanisms of diabetes remission following metabolic surgery. So some really good topics to be covered there. Without further ado, allow me to introduce Professor Torsten Olbers, okay, a real worldwide expert bariatric surgeon, well recognized and acknowledged and respected within the field. He has contributed hugely to the field of metabolic and bariatric surgery research. He's currently participating and running the BEST study. He runs an adolescent obesity surgery program, the AMOS, and he is also was also an active contributor in the Swedish obese subject study. And these have provided, as we all know, the best data out there and best level of evidence supporting bariatric and metabolic surgery. So he's currently professor of metabolic surgery in Sweden in the University of, here we go, Linköping. Yeah, we tried. So thank you ever so much for talking to us tonight. And I'll let you introduce your topic. Okay, so as always, audience, please post your questions via the Q&A button so that at the end of the talk I can moderate and ask Torsten lots of very difficult questions, and hopefully we'll have a nice lively audience. And tonight's topic I think is really important. Thank you very much, Torsten.
Thank you, Sharif. Thank you. It's a great honor to have the possibility to do this lecture, and I congratulate you for setting up those types of educational activities. I really want to mirror that in Sweden. Talking about educational experiences, I would say that the Swedish women's team in football had an educational experience yesterday, losing 4-0 to you in England. Congratulations, and maybe football is coming home after all. I'm going to talk about the JJ, the enteroanastomosis of the Roux-en-Y bypass construction, which we have found being a bit of the Achilles heel for the construction. And I'm standing a bit on the shoulders of my former boss, Hans Lönnroth, who initially presented this technique, and we developed that together. But I will show you a little bit of the journey with this technique and where we're now focusing on, where the sensitive parts are. Those are my disclosures, reimbursement to institution. I just first want to stress that sometimes I feel that we in the healthcare can almost accept that patients having pain and even vomiting after Roux-en-Y gastric bypass. I can see that oh yes, having pain and vomiting. I think it's really something that the perception that we need to strive for, that a normal gastric bypass, you don't have pain when eating, you don't vomit. Especially vomiting is very pathological, and many of you, of course, know that. So just to outline, I think I'm using EA or JJ as a synonym here. So if it's on different slides, just remember that. Abdominal pain that is coming not immediately after eating, but after a few minutes, you're starting to get pain in the upper left quadrant of the abdomen. And it's usually coming in intervals, and then it subsides after maybe half an hour, 1 hour, 2 hours. And they might even need to lay down in a certain position. Postprandial nausea, retching, vomiting. as mentioned, I think we should regard this as pathological. Of course, you can have dumping symptoms, but the patient knows what the dumping is. But if they say or more or less every time I eat, I have nausea and I vomit, then there is a problem. We also, I won't go deep into that, but we have also found that there are the worst cases of hypoglycemia when they can't even improve anything. They say that the only time I don't get hypoglycemia is when I not eat anything. You should think about a mechanical issue. I leave it with that, but there is some theoretical background to this, and we have found that this could be improving after intervention. Just so we get the picture right, the JJ, the patient's head down here, and you have an acute obstruction where we have the root limb here, you have the biliopancreatic limb, and you have the common channel. And when looking a bit closer, we can see that the surgeon here had been taking a quite big bite with a suture at the lower corner of this JJ. And this is the typical situation, isn't it, where we have this kinking phenomenon, where you have the acute obstruction just a few days after the operation. So what we did was to open up and put a stapler aborally. It's going to be in the common channel and the biliopancreatic limb, and then closing transversely. So you get a more square one without any narrowing down here. So the obstruction was obviously up here. So going into the, I'm going to present data from 2 different studies, and these are part of the PhD program for a young surgeon, Susanne Hedberg, working in Gothenburg, where I used to work at Sahlgrenska. So the first, the first here is a paper published in Obesity Surgery, and it's the same title as the talk today, about the Achilles heel of the Roux-en-Y gastric bypass with a gynostomy. We had a cohort of 115 patients at Sahlgrenska, which had been a bit accumulated over time, but we found that there was a problem that we, in many cases, could solve, and we wanted to structure what was the eventual outcome in this. So they had symptoms that were suggestive of a problem for the passage at something like the JJ. These are patients that have been followed for at least 1 year, but the mean follow-up after intervention was 2 years in this. And as you can see, about 40 to 45% were entirely symptom-free after having a type of revision that could either be a desmolysis or repositioning of the JJ, but also in quite many cases, a new creation of a new JJ. About a third of them experienced substantial improvement, that they could function well with a Roux-en-Y gastric bypass, but still had some symptoms. But there was quite a group still who had unchanged problems, and we come back to that reversed anatomy was an option that were quite common to use for those having those problems that we couldn't help with surgery. So the conclusion I take from this is that most patients, when you think you have a problem, postprandial problem, I'm stressing this because I think we so much refer to abdominal pain, but I think we should really separate between postprandial problems that's coming along with eating and those who are kind of more chronic. The chronic ones, really hard to help with surgery, but the meal related, much more close relation. We found also, and have found consistently over time, that it's very hard to diagnose those problems. Contrast is always going through. You can do as many CT scans as you want, but you will still not, most often not find any problem when doing a CT scan. We have done some kind of barium follow through with a more food. You add food and barium, you mix them and eat that. So maybe that can say, but it's very hard to outrule. So it's laparoscopy that's needed to diagnose this. And just to mention also that 1 out of 5 had persistent problems, and then it was often a reversal of anatomy that was needed to have an acceptable situation. So what is happening? And quite early on, we found that something happened when we started to close the mesenteric windows with a double loop technique, the Lönnroth technique. And if we see the paper from Lancet where Erik Stenberg published the Swedish data, where we did a randomized study between closure of mesenteric defects and no closure of mesenteric defects. And after 3 years, of course, you can see a substantial reduction of the risk of having a bowel obstruction, operation for bowel obstruction. This was halved after 3 years. However, if we look at the left side of this, we can see here that during the first year after surgery, when you had a closure of the mesenteric defects, you had a substantial higher risk of having a small bowel obstruction operation during the first year. So by gaining this, we actually introduced something that created some type of problem. This is, of course, the curve that we want to see, and that would have left us probably with a 2% risk of internal herniation. But you remember it was more close to 4% at 3 years in this study. So the technique we have done, and we come back to that, is to do different things to get a proper angle here and to liberate this part of the bowel so it can fall down in the abdomen and not creating the kink. We'll come back to that later. We went into more kind of hard data to look in the registry, our SOREG, the Swedish Scandinavian obesity registry, where we have, like your dendrite, having quite substantial amount of patients. And we were able to, within 35,000 patients, we could include almost 20, a bit more than 23,000 patients who had either 1 or 2 cartridges used at the creation of the JJ, but also the length of the mesenteric division between the anastomoses in order to liberate, as I mentioned before. So 1 or 2 cartridges, bidirectional or unidirectional, and different length of the mesenteric division. What we found when we compared the group in a multivariate analysis was that if you use the bidirectional JJ compared to the unidirectional, usually that was orally that you put the stapler in then. Like in the patient we saw that if using the bidirectional, you a bit more than half the risk of having a bowel obstruction, an operation for a bowel obstruction. But also we could find that when having double stapling, we had a trend towards having more bowel obstructions late. This is under 30 days after the operation. This is more than 30 days after the operation. Looking at mesenteric division, splitting between the anastomoses to make it fall down, we could see that that was a surprise, that it was significantly higher risk, 1.75, if you did a short division of the mesentery, while if you did a long division of the mesentery, it was not significant. And if you looked at the long-term outcome of mesenteric division, it was not significant, either with 1 to 4 and 5 centimeters. Slightly without logic here, that you introduce something that is actually increasing the risk of having an obstruction. Looking at the curves, we can see that if we put them together, you can see that if you did a unidirectional, just using one cartridge, there was not much difference between if you did no division, small division, or 5 centimeter division. And as you can see, the green line is actually the 1 to 4, so that was the highest risk, while the blue one is the 5. The beige one is the 5 centimeters. While if you do bidirectional stapling, we could mitigate the risk of having a bowel obstruction if we do a long mesenteric division. So if you do bidirectional more than 5 centimeters, you have the lowest risk. If you do no division and you have bidirectional, you have in this model the highest risk, and 1 to 4 middle risk, provided that you do bidirectional stapling. So concluding from this is that the risk of small bowel obstruction and needed to be operated for this is related to the technique for creating the JJ. Of course, we need to be very careful in saying that we have a causative relation here. We know that it's associated in those big figures, and we know that there are variations, but exactly what is right is hard to say. Bidirectional stapling appears to lower the risk of early small bowel obstruction, and a long mesenteric division mitigates the risk for long-term small bowel obstruction when you're using the bidirectional JJ. And if we did a post hoc analysis of the kind of the traditional Lönnroth technique with mesenteric window closure and the most modified one, the bidirectional with the 5 centimeters, you actually have 1/4 of the risk of having a bowel obstruction in the registry data. So if I just summarize this, I would say that those data suggesting that the surgical technique for constructing the JJ can affect the risk of having a small bowel obstruction. And it's also coming back to the first study to say that when you have a patient having those postprandial phenomena, consider going in with laparoscopy and doing a revision, and especially with a focus on the JJ. So what are the options, and what can we do to minimize this risk? And I will show a video just in a minute. But quite many started out, as I found it, to find some kind of harmonic bow in the bowel that goes past the JJ, and maybe even an anti-kinking stitch. Quite early on, I started to do bidirectional stapling, and for different reasons. Usually, for our surgeons, that we had some patient that had a clot ending up in the JJ, and I wanted to do as safe as possible. But anyway, that's the story. But also splitting the mesentery to make the JJ falling down into the abdomen. So let's go here, and I hope I can bring up the video. Could you please just indicate whether you're seeing the video now?
Yeah, all good.
Great, super. Okay, so this is a quite lean patient, which is lean inside at least, but it's quite good for demonstration purpose. And I'm just it's an 8-minute video, so I think we have time maybe to go over that. And I suppose that you stick to the small pouch, most of you. I've heard quite much trend from different sides, especially in Netherlands, that you are lengthening the pouch of the stomach pouch. I feel a little bit hesitating about this because we have a history of having stomal ulcers when we're doing the pouch is bigger. So I'm trying to do this pouch as small as technically feasible, and that's usually some 10-15 milliliters. Okay, and just 1 or 2 cartridges there. We can maybe fast forward a little bit. Oh, sorry. I think, okay. That was a bad idea to try to fast forward it. Okay, let's go back, and we just take it as. Do you think we have time, Sharif?
Yes, I think you're good to move past making the pouch. Yeah.
Yeah. Good. Excellent. So here we are. Okay. Yeah. Sorry. I was just misinterpreting that. Okay. Anyway, it's 3 centimeters of the cartridge in the bowel, and 3 centimeters of the anvil in the pouch, and yeah. Having a wide open anastomosis and not aiming at restricting the passage anyway. I'm not a believer of any type of restriction. I think we rather the opposite, that we depot the nutrients into the bowel. Let's see here. Yep. Okay. Okay, so that is nothing spectacular with this. Okay, so a small pouch, the size of the bowel, and here we go. Now we come to the next moment, and I usually do the closure of the Peterson space at this point, where I think the bowel is lying quite nicely. You don't need to go back to flip the roux limb again. So here you have a good possibility in the middle of the operation to do the closure there. And I usually try to get it a little bit to the patient's right-handed side, so you get the roux limb going in the patient's side to the right for better harmony. Either I can do as well metal clips, but for a long time I used the AA suturing to be the safest in this. But I suppose many of you are using the clips now. Okay, now we are approaching the JJ. And just measuring the roux limb. I usually do it 100 centimeters. I don't think there's any need for doing a roux limb longer than 100 centimeters. We don't improve the function by stretching out the roux limb. Try to get the incision in the biliopancreatic limb very close to the GJ, and in this patient, I'm using some 2.5 centimeters cranially, and then doing about the same length caudally here or aborally. Nowadays, I probably use a little bit more. I use close to 4.5 centimeter distally, and just a little bit in the cranial position. If we just stop here a little bit, we have the staple line there, we have the staple line there, and then we can suture. When doing the bidirectional stapling, the good part is that you can suture horizontally or transversely, rather than doing it in this way that we need to do if we just use one stapler. So we just see how this looks when getting ready. Okay. This is just, but I just wanted to stress that you get a little bit more of a square anastomosis here. You don't get any narrowing or bends on the bowel there. This I think is a good trick to flip out the rouleum, so you get a good view of this part of the mesenteric window where we can see deeply. I'm using the bowel to suture that, but I using it as a stay suture. And then after just putting this stay suture, I'm opening up and splitting the bowel between the GJ and the JJ, and hopefully not too much of loose ends here or stumps. And here comes to the split of the mesentery, and here with the patients quite lean inside, you can see that we are now approaching the first arcade of the vessels, and this is probably where my colleagues not feeling too comfortable with splitting too long here, but I'm definitely splitting more than 5 centimeters, and in most cases I split maybe 10 centimeters nowadays, because when you come through the first arcade you can go 5 centimeters more quite easily. And here you have a good lift here with the assistant, so you have a stay suture, it's lying quite nicely. You can use this split mesentery here and use the first part of the peritoneum to the first line, and then when we go backward we can use the second line. And if you have clips, I use in more or less the same manner, that the first line is with the first end, and then you go to the second layer of the peritoneum. And I think we get a quite nice position of this, where we have a you will see in a minute where here we have just the leak test and nothing about that. But if we're now looking down here to the right, we can see that there is nothing inside here about the JJ. The JJ is falling down, and I even put the left part of the omentum over it, just to have this split of the two anastomoses. Okay, I should stop sharing here. And I just want to thank again for the opportunity to speak, and I'm very glad to take questions if there are any. Thank you very much.
Yeah, thanks so much. And it's always such a pleasure to see somebody else operate, because you pick up lots of tips of what you do. So if I was to ask you, so your ideal JJ then, from your experience, from what I gathered from the data you presented and so on, so bidirectional, so you like the bidirectional technique as opposed to the unidirectional, and 5 centimeter minimum split in the mesentery, yeah?
And now we're talking about associations, and as I said before, that I've been going in that direction. A while ago, I actually thought that maybe we don't need to do a bidirectional, so I started to do again unidirectional. But after 2 patients coming back with obstruction that I needed to do an additional stapling, I went back again to this at the safer side. And I also want to stress that it's not high figures we are talking about. We are now talking about the last percents of patients, but having a decrease of a half or 1% of the severe complications. I think that's quite good if we could aim at that. But again, we don't really know for sure what is the best. We probably need some type of prospective study to find out that that is not just association, that is causation.
Okay, so just while we get a few more questions via the Q&A, we've already had a couple, but are you not worried about intersusception of the anastomosis with the bidirectional technique? That would be my worry.
That's probably the most common question. when looking at this, and I appreciate that. We looked at that, and we didn't have any more interception with the bidirectional. There is one other paper also addressing this, and I can't outrule that there would be an interception problem, but it didn't appear in our studies that we've done so far. The interception at the JJ, that is a weird thing, isn't it? Yeah. Because it's happened in a way that I almost regard interception as some kind of symptom rather than the causing problem, because it's invaginating from distally to proximally, and it usually goes into the JJ or just in the close proximity to that. So from my point of view, I actually more picture that as a symptom of a dysfunctioning JJ because it's working, and yeah.
Okay. Any tips for reducing the risk of clot obstruction at the JJ? What have you found from your thousands of patients you've operated on? Have you changed your technique in any way? Is there anything surgically that we can do to reduce the risk of clot obstruction at the JJ?
One thing is to use a white cartridge at the GJ, so you don't get those oozing bleedings that eventually ends up as a clot. We did in the SOREG registry, we looked at this. Are there more leaks when you're using the white cartridge compared to the blue cartridge? Because I suppose you're also registering the cartridges, but there wasn't. So we had a reduced number of bleedings, but no more complications from leak. So white cartridge and beige, of course, or tanned. With a Medtronic, but as a matter of fact, it's those means I've taken. Those are more or less to avoid cloth stop or bolus from food or anything. It's just to make it. Sometimes I say that it should be a room-wide bypass should be tight. There should be no stumps, and it should be tight. It should be floppy, so the JJ could move around. So it shouldn't be stuck there up with the GJ, and it should be non-sticky, so you don't get those sticky parts where you have the momentum when it shrinks. It's getting distortions. I think you've seen that when you kind of you see all of the construction out to the left of the patient. I think that's usually shrinking phenomenon that's happening.
Really, really useful advice. I'll go to the Q&As. Just a few questions here about the revisions that you've done. So what percentage were done laparoscopically? You showed a picture of an open revision, but I assume you're doing most of these laparoscopically. What sort of percentage?
Yeah, it's actually 100%. It's 100%. I thought that it just made the point with the open one, but it was 100% laparoscopic, and yeah, it's
okay.
The natural part. Yeah.
Question about closure of the JJ enterotomy. You closed it in 2 layers. Is that true that you do a 2-layer closure, or is that just an old video?
No, I do that because, and that's again 2 patients, n equals 2, and you can. I had when you do bidirectional, you have 4 corners coming together, and I had 2 patients having a leak in the middle of those corners. So it's a kind of a weak spot there. So that's when I started to do the 2-layer, and I just find it convenient that you don't need to be very precision in the first layer. You can take a little bit bigger bite, so you have approximation, and then you're getting a little bit more meticulous in the last one, and then you take a little bit bigger bites when those corners are coming together in the middle. Okay.
And I noticed, because this is a very technical talk, I noticed that you didn't leak test your JJ when you did it before you divided.
No. Are you doing that, or is that common in?
Some surgeons do. Some surgeons
Yeah.
will clamp all the ends and leak test it before they
Mm.
actually divide in the omega loop technique. It was just an observation, that's all.
Yeah.
A question here about the length of the JJ. So from James Hopkins, so he's saying most surgeons, a lot of surgeons use the 60 millimeter staplers. Now you're bidirectional, 45 millimeter one stapler and 25 one way. So do you think instead of doing bidirectional, if surgeons used a 60 millimeter stapler unidirectional, it would achieve the same effect?
It's a good question, and I quite often get that too. But my view on that is that you are not addressing the root of the problem by lengthening in one direction, because then you still have the lower corner of that. If you staple from below, you will still have the corner of the cartridge or the staple line. So whether you have that 45 or you have that 60 or you take two 45s, I don't think it really makes sense. I also want to avoid that we get this ballooning. I think many of you have seen this coming in, and you see this type of JJ. And then, of course, you're getting some kind of Laplace phenomenon that is getting distended, and you can have pain from that. So, yeah, I've been a little bit going back and forth. At some point, I was really minimizing in two directions, but now I came to this that I should currently I'm doing a little bit upwards, 1.5 to 2 centimeters, and most of the cartridge downwards.
Okay.
I think another technique that some colleagues of mine are using is to staple only from above. And I think if we should do a study, we should probably have that also. Because what you get then is that you will probably not have a kink at closing the drainage from the biliopancreatic limb. You will have still a drainage from the remnant stomach. But yet you get the kink in the upper corner. But I have some colleagues saying that this has been helpful for them to staple from the other direction, okay, if using just one.
What proportion, because I'm going to ask you about the bypasses which don't have a JJ. I know it's not the topic of today, but what proportion of patients in your experience with a standard Roux-en-Y gastric bypass would you expect to have a problem with the JJ? In terms of when you're consenting them, would you say about overall, if you're to take your whole series, 10% of patients, 5% of patients? In your experience, what number?
Yeah, that's a very good question, which I really would like to have a good answer to. but I think the more we are addressing it, the less we are seeing this. I think what I want to say with this lecture is not to say that I have found the perfect technique, or please do everybody that I do. I just want to mainly address the issue of that there can be problems at the JJ, but my perception is now that it's at least less than 5% that's having some kind of problem, and I would say that the thing I'm a little bit afraid of is that we have some that, for example, this one we saw with the open surgery, where it was extremely obvious that there was a problem or the kink. But if you have those who are obvious and getting an operation, how many are there that having a tendency of kink, that just having problems eating and occasional vomiting? And I think there's a gray zone there where some techniques might even have up to 5-10% that have some kind of impaired way of eating or occasional abdominal pain. I think it goes into this that we have had so many talks about bypass and abdominal pain. one thing is that I think whenever you do an abdominal operation, if it's a sleeve, you will also have patients with abdominal pain. But those who are having pain because it's been an issue, firstly we looked after internal herniations, but now we more and more that we are preventing internal herniations, we are looking for the more subtle things like minor kinking and other things.
Okay, and I'm assuming that you have a fairly low threshold for diagnostic laparoscopy. So if you see that this patient post-op in a clinic highlighted to you, you're getting the typical symptoms that make you suspect a JJ problem, would you bother with a CT or would you just book them for a diagnostic lab?
If it's typical, I just pick them for a diagnostic lab. Okay. I do that. A very low threshold, and I think it's fair to do that. And that's the beauty of laparoscopy, isn't it? That we don't need to be so defensive. We can be quite active, and as long as I'm also putting the question. Usually, it's after 2 years that we can really assess the patient. After 1 year, yet you have problems, yet you're vomiting occasionally, they will say, oh, might be, but it's fantastic. I lost weight and everything is good. But after 2 years, the patient will say that, is this really sustainable that I will live the rest of my life with these problems? So I think 2 years is a good time point to assess. And
in the UK, we discharge most of our patients on the NHS, as you know, at 2 years. So this is the difficulty we have with our follow-up. A few quick fire questions for you just before we run out of time. Yep. So Vinod Menon, president of BOMSS, he thanks you very much for a fantastic talk.
Hi, Vinod.
We just want to know, so you presented data on 115 revisions. What was the mean interval time between the index operation and revision? What was the mean time?
Hi, Vinod. Thanks for the question. Great question. I should remember, but I don't really remember. But as I remember it, it was some between 2 and 4 years. It was in that time span. But it was quite variable, and some of the patients had diagnostic laparoscopies finding nothing at other hospitals, and this is also an experience that you can, if you don't appreciate that this could be a problem, you can easily look in and say that there isn't a problem. That's been my experience.
Okay, and Dimitri raises a very valid point that it's definitely time for an RCT combining our 2 registries, because we've got 2 great registries in Sweden and the UK.
Good idea.
I couldn't agree more. And then we have a question about the anti-kink stitch. Where's the best, given that you're splitting the mesentery 5-10 centimeters, where's the best place to put your anti-kink stitch? And do you still would you still put an anti-kink stitch if you're doing bidirectional and splitting the mesentery?
No, that's actually the first question. Should we put the anti-kinking stitch? Yeah. I'm not using that anymore. But in a way, as you saw, my closure of the mesenteric window starts out at the bowel, in the bowel. So if you do that, you can use that almost as an anti-kinking suture. But I'm not using anything that is 1 or 2 centimeters from. It's I try to keep it quite tight.
Tight. Okay, fantastic. Well, we've exhausted the questions and you've presented an absolutely fantastic talk and lots of really helpful technical tips for us, Torsten. So thank you ever so much for the talk once again and sharing your expertise.
You've been way too kind to me.
Not at all. I only speak the truth. Right. So thank you all very much for joining. Thank you to Gore. Next couple of sessions, 10th of August, Wednesday, is the Journal Club run by the Phoenix team. And then the next educational webinar, the 4th Wednesday in August, which is the 24th, Professor Iskender Idris, metabolic physician at Derby and EMBMI. He'll be talking about mechanisms of diabetes remission. This talk has been recorded, so BOMSS will email out the recording in the quarterly mail shot that we do. So thank you all very much. Torsten, thanks once again and lovely seeing you.
Good luck at Wembley.
Thank you. Thank you very much. Good night.
Bye-bye.
Bye-bye.